little bit about herself. But I'd like to introduce Anu French today, who's going to be talking with us about PANDAS. And she's a dear mentor, a friend, a roommate at conferences. So I'm delighted here to be able to share and learn from, again, Dr. Anu French. She's been in she's been a pediatrician for 29 years, and she has opened and director of the SSM Health Cardinal Glennon Primary Care Office in St. Louis, Missouri, where she takes care of kiddos with complex medical issues, amongst which are PANDAS. She's a fellow in the American Academy of Pediatrics, double board certified in integrative medicine and pediatrics, a course director in integrative pediatrics for the 2024 Integrative and Functional Medicine Fellowship at UC Irvine Susan Samuel Integrative Health Institute. She also has a terrific newsletter, which I subscribe to and suggest that you will as well. Facebook website, lots of great practical information for taking care of children. So it's my great honor to introduce Dr. Anu French.
I just want to again say thank you for this opportunity, because I'm always so grateful for all the people who continue to be teachers and mentors to me in this field. And when I have to share on PANDAS, it gives me an opportunity to go back and look at what's out there, what research is, making sure I'm staying within evidence-based guidelines and I'm staying on top of everything that's being offered in this area. So the World PANDAS Awareness Day was just on Wednesday. And, this is a vast topic, and we are not going to be able to cover all of it in 20-25 minutes. But the whole goal, I think, of the learning objectives is just I want people to know that this is a real disease. It exists. And if we can recognize it quickly and shorten the time between onset and treatment, we can really help these children. And I want to review sort of the consortium guidelines and algorithms through an integrative lens. And I'm hoping that's what we can achieve today. When I heard PANDAS for the first time, the talk for the first time, I was completely overwhelmed and I had so many questions, and I didn't feel like there was a lot of great resources to go to. There were a lot of resources, but I couldn't find anything that was completely evidence-based. And in 2020, Dr. Sue Swade, who coined this term, she put together this website, and it's very much driven by PANDAS parents too. They do a lot of the work on the back end. And I feel very honored to serve in a voluntary capacity on the professional advisory board. And so everything on this website is evidence-based and vetted, and it's just got toolkits and research and advocacy for legislation and anything that you might need to know that you want to learn about this topic. This is the website I would direct you to. About me, I feel like it's important for me to share that, I'm approaching 30 years in practice, but 15 years ago, I was completely burned out, professionally and personally. And I just was bored and tired and kind of done with pediatrics. And I stumbled on these fellowships and this whole wonderful world of integrative medicine and this global community. And I clawed my way back from burnout through the creative arts. And I think today my most important intention, just being on this planet, really is to build intergenerational resilience for myself, for my two daughters who are now 18 and 21, and they're venturing out into this really chaotic, scary, stressful world, and also for my patients and their families, because since we opened this clinic 5 years ago, all I see is medically complex, chronically ill children with stressed out families, and I feel like I've got to know how to self-regulate myself in order to be able to offer tools of self-regulation. And so all my intention through everything that I offer is that goal of building resilience and changing structural systems that don't support it too. So these are patients that I've seen in my office. So a 12-year-old girl with an abrupt increase in anxiety, OCD, sleep resistance with separation anxiety at night, decline in executive function and handwriting, and absolutely refusing to go to school. A 6-year-old boy with sensory processing and disorder and emotional dysregulation, scared of bugs, can't stand smells and loud sounds, and doesn't want to be touched, urinating multiple times a day, every 30 to 40 minutes. A 9-year-old girl with an acute onset of restrictive food behaviors because she's afraid she's going to choke on her own saliva, complaining of air hunger, like she can't take a breath, difficulty swallowing, and is constantly checking expiration dates. A 15-year-old boy with a transient tic disorder that abruptly becomes worse, chronic cough, throat clearing, humming, clicking, baby talk, talking like a 2-year-old, behavioral regression, afraid he's going to be abducted by aliens and absolutely won't sleep by himself. So this is just a snapshot of what I see in my office. And clues in the history, I think, is really important. A change in behavior that steadily worsens or persists. It doesn't have to be abrupt. It doesn't have to be in a totally previously neurotypical kid. And even if there's a social excuse, like some kind of psychosocial stressor, not to blame that on this disease on that. So this is a survey that was done that showed how long it takes for diagnosis. So if you look at the graphic, almost a third of the patients took almost 3 years before somebody made a diagnosis, a third of them between 6 months and 3 years, and another third of them less than 6 months, but it's still 6 months. And what they saw was that most of these patients saw at least 3 doctors before the diagnosis was even considered. More than half of them, so 5 doctors. Very typical of kids who end up in my office. They've seen almost everybody. And the most common initial diagnoses are those that are going to bring them to your offices, to a psychiatrist's office: OCD, anxiety, ADHD, and then oppositional defiance on the autism spectrum, Tourette's, and tic disorders. And another study recently done showed the treatment barriers to these kids. 80% had delayed diagnosis at least a month after the onset of symptoms, that if somebody even thought about it. And the most encountered causes for the treatment delay were the clinician's lack of awareness and the clinician's skepticism about the disease. So there's so much medical gaslighting in this disease. It's just unacceptable. The other common challenges were difficulties finding somebody to actually take charge of the care and misdiagnoses. So definitions, if we go back to 1998, Dr. Sue Swado was published that first case series where she called it PANDAS, and she saw these children who had strep and developed an abrupt onset of OCD and anxiety and tics and so on, and she called it PANDAS. But that definition has evolved and expanded over the years, and in 2013 and then in 2017, these consensus consortium guidelines came out, and these were groups of people across the country who are all treating this disease in various capacities, who kind of came together to create some sort of common ground. And so they expanded the global sort of the umbrella term to be PANS. So that's pediatric acute onset neuropsychiatric syndrome. And then if it's an infectious trigger, if it's caused by strep, it's called PANDAS. If it's caused by other infections, it's called PANS. I'm not really going to touch too much on the non-infectious causes, and I honestly don't go too much into that into my practice. I think just trying to deal with the infections is there's plenty of patients struggling with that. I would say the one thing that I would add under other microbes is COVID. COVID has kind of been sort of a silver lining or a blessing in disguise, because it's really shown us how an infection can actually cause a neuropsychiatric syndrome. So this is a recent paper in 2024 that really goes into depth as far as just this multifactorial etiopathogenesis for this disease. So we have some genetic predisposition. We definitely have molecular mimicry. We know in acute rheumatic fever and Sydenham's chorea, we don't question the fact that the patient gets a strep infection, develops antibodies that become autoimmune and attack the basal ganglia and the heart. This is exactly what's happening in PANDAS. We have cross-reactive autoantibodies. They target, there are brain imaging studies that actually show microglial activation and structural changes in the caudate and putamen of the basal ganglia. So you look at the slide, if you look at on the right side, you have patients with Tourette syndrome or OCD, but they don't have PANDAS, and their brains look very similar to just controls who have no symptoms. But if you look on the left side of the slide, you can see that patients with PANDAS have brains that look very similar to Sydenham's chorea. The newer sort of pathogenesis theories are that maybe group A strep is actually altering gut microbiota, that it's actually selecting specific dysbiotic strains that are upregulating intestinal inflammation and immune response. And it's this persistence of this response that causes this kind of waxing, waning, relapsing, remitting course. Interleukin-17 is really emerging as an important cytokine in the immune response, and we'll talk later about some studies in mouse models. But in the world of rheumatology, they're really seeing how these patients develop arthritis that is driven by IL-17, suggesting that this is not really like a psychiatric disorder, but it's actually the brain's response to a global inflammatory process going on in the body. And then just high rates of autoimmunity in first degree relative, 60 to 70%, higher incidence of PANS in patients with specific HLA alleles, and the response, how these kids dramatically respond to immunomodulatory treatments. It's really really impressive in the office. So focus on history. You know, we're looking at boys. It's more common in boys than girls. There's a family history of autoimmune disease, recurrent URI, sinus, ear, nose, throat, that kind of history. But we have almost 80% of them don't sleep. 98% of them show some sort of a behavioral regression. 90% of them show urinary symptoms, frequency, urgency. They all have these sort of this phenotype that looks like ADHD: concentration, learning difficulty, short-term memory loss, inattentiveness. They have handwriting deterioration. Dysgraphia is really, really pathognomonic of this disease. Many of them have restrictive food behaviors and they have severe tics, tic disorders, vocal, motor, facial, masturbatory tics, also focusing in the private area. So how do we diagnose this? It is a clinical diagnosis. We do not have a diagnostic test. And so we have major criteria and minor criteria. The major criteria are a sudden, acute, or worsening of obsessive compulsive disorder, severe restrictive food behaviors, and a tic disorder. So on the left side, and this is from my EPIC, this is, so please feel free to use it if you can put it in your notes, because I use it in my notes. So on the left side, you have PANDAS criteria. So if you have one of the major OCD or restrictive food behavior and two of the minor criteria, which are anxiety, lability, aggression, behavioral regression, ADHD, and then like sleep and urinary symptoms, two of those seven. On the right side, you have PANDAS. You have either OCD and or tics as the major criteria, and then the minor criteria, again, the same two of the minor. And then there's usually a history of strep, but it's really important to know that you may not see strep acutely in the moment. And so even a history of a rash, history of palatal petechiae, exposure to a strep case at the time of symptom change, or an asymptomatic carrier in the home, or anything that's documented 3 months from the time of a documented strep case is definitely considered enough to make the diagnosis of the PANDAS. Now, these forms, I've given you links. This is the form we use in our office that patients fill out when they come in for their first intake. And then this is the form we use at every visit. And it's really, really wonderful to see with treatment how they go from the right side all the way to the left, from red to green, with each visit as they get better and better. So it's a real great snapshot to look at how a kid is doing in real time. Physical exam is really important, looking for infection in the ear, nose, and throat, allergies, coated tongue, strawberry tongue, palatal petechiae, perioral redness, chapped, cracked lips, mouth sores, and then teeth become a very important dysregulator of the immune system. So making sure that the oral microbiome is healthy, looking at their skin, careful exam for impetigo, intertrigo, hives, warts, and molluscum, again, are huge immune dysregulators. Looking at the genital area, for rings and redness and yeast infections and perianal strep and vulvar strep, peeling fingers and toes. Acro peeling is a sign of strep somewhere in the body. Damaged nail beds, chapped hands, and then looking for tenderness and musculoskeletal. Many of these kids are extremely hypermobile, which Donna could probably speak more to that, about overlap between the mast cell dysregulated kids and these kids that seem to affect their joints, in the Ehlers-Danlos syndrome, kind of in that spectrum. And then when they come in crisis, they all have dilated pupils. And they have these choreiform movements, so having them stretch out their fingers, and they do this little piano playing. And then if you ask them to make a fist, they kind of do this little milkmaid. It's called the milkmaid sign. But these are all signs of basal ganglia encephalitis. And then left-sided neglect. They just neglect the left side of their body. And sometimes when they're writing on the paper, they will only write on the right side. So there's something about this left-sided neglect. And then obviously making sure that they don't actually have rheumatic fever. So this is these are wonderful photos from many of my mentors and teachers in this field, Dr. Sue Suedo, Nancy O'Hara, and Dr. Peter Klinger, who taught me so much on this disease. And this is a kid, you can see when they're completely healthy, they can draw that beautiful microscope and perfect penmanship. When they're in a flare, they can't write a straight line. They're scribbling like a 2-year-old. They can't color within the lines. So you can just see such significant difference in behavioral regression and dysgraphia. So I think that not being able to write is really an important red flag. So this is a flowchart from the PANDAS Physician Network. I think it's a good start when if you have a patient in your office and you're like, okay, what do I do next? So on the left side, you can see the 3 major criteria in green, and then the yellow criteria in the box below. So let's say you have a patient who satisfies criteria, you do the strep, it's positive, takes you all the way to the right side of the chart. they've got the comorbid symptoms. You go down to the bottom, you've made a diagnosis, it's a clinical diagnosis, and then you can kind of see are they mild, moderate, or severe, and you manage them. But if they don't have a positive step right away, then you can send off a culture, get some blood work, and then wait on the results. And then if they have tics and they have minor criteria, then they have the disease. If they have OCD in the minor criteria, yes, they have the disease. And then if they only have tics but no criteria, or they only have OCD and no criteria, or they only have restrictive food behaviors and no criteria, then we have to be very careful about making this diagnosis. So I think it's a helpful start, but we'll go into kind of the way we approach it in our office. So there's no biomarker yet. So there's a lot of work all over the world looking at signature cytokines and metabolic profiles and looking for actual like auto antibodies, specific auto antibodies and sera. So all of that's going on right now, but right now we don't really have a diagnostic test, which is why it is a clinical diagnosis. And so you look beyond the throat, cultures of the perianal area, the nares, the skin, look for cultures. For staph is another huge dysregulator of these kids' symptoms. It may not be a cause, but I often find staph, MRSA in the nose. Urine is important just to make sure you're not dealing with a UTI. And the blood work I get blood counts and inflammatory markers, strep, titers, iron studies, vitamin D, thyroid studies, mycoplasma titers. There is data to show that an IgG and IgM mycoplasma is as good as a PCR, so you do not have to get a PCR. Looking at an ANA and quantitative immunoglobulins to look at a general look at the immune system, and then an EKG, basically in preparation for using medications, and also to rule out rheumatic fever. So it's important that we swab family members, because a carrier in the home, a silent carrier in the home, can completely derail a child's treatment plan. Strep titers rise, ASO in 1 to 6 weeks, DNase in 1 to 8 weeks, and the anti-DNA stay positive for a long time. But 40% of children with PANDAS and strep do not mount an immune response. So again, that's why titers are not pathognomonic, they're helpful. And antibodies, we never treat antibodies. So if your child does not satisfy clinical criteria, I would not be running tests on these kids, because there are going to be lots and lots of kids out there with positive titers. And mycoplasma, like I said, IgG and IgM titers are very important. And I would say the #1 cause of PANS in my office is mycoplasma. So it's really important to rule out all these serious diseases that can sort of look like PANS, because it's still a diagnosis of exclusion. And then, I get a lot of specialties involved to co-manage these kids with me. And this is, these are the specialties based on the reasons why I refer to them. And as you can see, psychiatry is right at the top. So these are consortium treatment guidelines, and they really want to emphasize this three-prong approach, that we have to have psychotherapeutic treatment with medications and behavioral therapies and school involved and all of that, as well as treating with immunomodulatory therapy and antibiotics. So they recommend a course of anti-streptococcal treatment for all new cases, chronic secondary prophylaxis for those with recurrent or severe symptoms, vigilance for new infections, using NSAIDs, and using steroids for patients who are flaring, as they call regression. And then they go into sort of the other treatments that are really sort of outside the scope of the primary care physician, but IVIG and plasmapheresis and so on. And then they also recommend attention to vitamin D levels and probiotics. But really the most important thing is that psychiatric care is really, really important. So, we kind of, in our office, we look at how do we find symptom relief for the child and hook them up with the right psychiatric medications and therapies. How do we treat the source of inflammation, whether it be bacterial, viral, or fungal? How do we treat the immune dysregulation with NSAIDs and steroids and other integrative modalities, and other things we do think about as a tonsillectomy, and using antihistamines and making sure vitamin D and omegas and all the other things we do as integrative providers. So in our office, we take a thorough intake, which I shared the forms. We do a thorough physical exam. If they meet clinical criteria, then we take all the swabs that we talked about. We make sure we're ruling out other differential diagnosis, get the lab work going, make all the important referrals, hook these patients up with therapy and school and so on. And then we start treatment. So we start with a trial of NSAIDs and a trial of antibiotics. And so for me, the therapeutic trial is part of the treatment to see if they respond. I don't always go to steroids with the first visit, depending on how severe they are, but we definitely do some kind of anti-inflammatory and antibiotics. And then we always also address gut and exercise and mindfulness, sleep, screen time, all the things that we do for every patient. So a little bit about this. We use 5 to 10 milligrams per gram per dose twice a day with food. These are really important. I think that the most important thing is putting out the fire, like getting the inflammation under control is really where we see the symptom improvement. I always protect the stomach with either an H2 blocker, or we put them on slippery elm or DGL or aloe, something like that. And then if they're really severe and they need steroids, we can do a short burst, just like you would treat asthma. An asthma flare, we don't hesitate to put kids on steroids when their asthma is out of control. It's exactly the same thing with these kids. And occasionally we have to go to a 30-day taper, which is in the slide. But that is when kids are extremely severe. Antibiotic guidelines from the consortium. So they recommend, penicillin can be used, although there's a high rate of treatment failure with that. Bicillin is on shortage, at least in my part of the country, so we have moved away from that. Keflex can be used. It's better than penicillin for the post-strep exacerbations, great for UTIs and skin. My choice, my favorite one is Omnicef, because it actually can treat tics and OCD, as well as being an antibiotic to prevent further infections. I'm not a great fan of Augmentin because of it promotes a lot of yeast and diarrhea and things like that, but it is very effective. Another one of my favorites is the Zithromax. You have to get that baseline EKG to rule out QTC, but after that, it's such an effective antibiotic, and it's long acting and it's immunomodulatory itself, and it can be used 2 or 3 times a week as opposed to every day. Clinda and Doxy are really more for the allergic kids, the resistant mycoplasma, the resistant strep, the carriers, the dental infection kids, and tick-borne, which again, I don't do too much of the tick-borne disease, but can be used for that. And just the studies show that, early diagnosis and long-term prophylaxis really reduce the risk of progression to disabling chronic neurological sequelae for these kids. And so there's so much hesitation, I think, to use these medicines long-term, but I think we just wouldn't hesitate to use long-term medications in other chronic autoinflammatory diseases. We don't question when kids with juvenile rheumatoid arthritis or Crohn's disease or some things like that are on these chronic medications. I think we need to start looking at PANDAS through that filter. So these are just some integrative options that we use in our office, making sure the diet is cleaned up, prebiotic and probiotic foods. I use antihistamines. They're not part of the consortium guidelines, but they're extremely important. Again, but that histamine dysregulation, that mast cell dysregulation seems to be a part of this disease. And so I usually put these kids on hydroxyzine. I will use Periactin for the kid who's food restricted. I like Claritin and Allegra, Benadryl. Kind of moved away from using Zyrtec and Zylsal because they really cause a lot of bladder irritation. These kids are already peeing every 30 minutes. Love the flavonoids, which can definitely stabilize the mast cell. I'm moving away from just using NSAIDs as a rescue medicine, or just for that first couple of months, and then trying to move to curcumin and omegas and PEAs for the anti-inflammatory. Making sure we're looking for yeast all the time, because again, yeast is a dysregulator, and treating with diflucanoistatin. And I've used a lot of the other herbals and supplements, olive leaf, MCT oil, garlic, and so on. And absolutely important is making sure that vitamin D and iron are optimized. That is a huge part of the neurotransmitter health. And then I think if you don't take anything else away from this talk, but this one slide, using SSRIs in kids with PANDAS, they are extremely labile when it comes to neuroinflammation, and they do not tolerate SSRIs as regular doses. And so they need to be started really low and slow. And I would say that 25% of the dose might be enough for them. So starting low and working up to about 25% of what you normally would use is really important, because I see kids come to me from psychiatrists all the time who are on 100, 150 milligrams of SSRIs, and they are just going crazy on those doses. So, and then I just listed the other integrative remedies that we use for anxiety and OCD in addition to SSRI. So theanine, lemon balm, magnesium, omegas, lavender for the anxiety, NAC, inositol, CBD, lithium, and ashwagandha for those. These are things I use quite a bit in our plans. Just a quick word on tonsillectomy. I think my time is running out. It's not recommended standard of care, but it can be beneficial. We know that we take tonsils from kids with PANDAS. They have all kinds of cytokines in them that are not there in kids who are just have their tonsils removed for sleep apnea. And when we look at what they're growing in these tonsils, they've got staph and strep. In addition to strep, they have staph and gram-negatives and all kinds of bacteria that should not be in the throat. So clearly these are repository infections that are dysregulating the immune system. But this mouse study was so elegant because they took these mice and The nasal associated lymphoid tissue, the NALT, is what is kind of equivalent in the mouse to the sinuses and the tonsils and adenoids. And then they induced strep infections in these mice. And they found that these TH cells differentiated and they actually climbed up through the cribriform plate along the olfactory sensory axons directly into the brain. And then these cells released these cytokines that broke down the blood-brain barrier. And then these autoantibodies actually crossed and attached to specific neuronal targets. So this is what we hypothesize is happening. Every time a kid gets an infection, this is what's happening to them. So their blood-brain barrier is getting leakier and leakier, and their basal ganglia is getting more and more targeted. And that is why the chronic antibiotic therapy to prevent secondary infection becomes so important. So the teeth, this is something that's overlooked a lot in this world. It's really important that these kids have a healthy oral microbiome because there's strep in the mouth. And just like we prophylax patients with heart valve abnormalities, we recommend prophylaxing these kids when they have dental work or they have loss of teeth, braces, loose teeth. I see kids come in severe regression because they have a loose tooth. And so just trying to make sure that that's looked at also. And some of the things we do in our office, we make sure everyone's on a xylitol mouthwash or lozenges for oral health or a nose spray for sinus health. And we also make sure they're all on the Bliss K12, like the strep salivarius K12 probiotics for the oral microbiome. Prevents COVID, prevents cavities, prevents strep throat. So these are more resources for you. These are the books that I recommend. Dr. Scott Antoine recently released a fantastic book, the green one, which is a really comprehensive guide to managing this in your office. Dr. Nancy O'Hara, she's a leader in this field, released her book last year. I like this book by a naturopathic doctor, Dr. Jill Krista, Light in the Dark. Websites I mentioned, Aspire, but there's several. And then all the research that I've mentioned in this talk are these two links that are up there. It will take you to all of that research. And so just the take-home points, I think just to remember, it is a spectrum illness, so all kids don't have all symptoms. If you see a kid with a change or an acute onset of tics, OCD, anxiety, and if you see symptoms like this frequent urination with no explanation, dysgraphia with no explanation, restrictive food behaviors, which are odd, they're not body dysmorphic behaviors. That's really important to note. These are not kids who want to be thin. These are kids who are afraid to swallow. Sleep, school avoidance, and the baby talk regression to think of this disease. And it's a relapsing remitting course, so it's really important to kind of create fluid access with school and mental health services and not allow anyone to blame the kid, but establishing the correct diagnosis, providing the symptom relief, finding the cause and treating it with whatever that may be, and then making sure that we're cutting back sort of on some of the medicines that we're using and then just using them for flares. So that's kind of the management guideline. So that's that in a nutshell.